Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
Well, both benign and malignant tumors or neoplasms can arise from any soft tissue, like muscle, or any bony tissue of the arms, the legs, the pelvis, the shoulder, or the trunk, meaning the ribs and spine. Now, if the tumors are malignant or cancerous, they're called sarcomas, and they can metastasize or spread elsewhere, causing all kinds of trouble.
Compared to tumors at other sites like the breast, prostate, kidney, or lung, tumors of the bones and soft tissues are relatively rare and are often treated by a team of physicians, one of whom is a surgeon called an orthopedic oncologist, someone specially trained to manage these patients. And here to join us today is the Division Chair of Orthopedic Oncology at Mayo Clinic, Dr. Peter Rose. Welcome to the program, Dr. Rose. It's nice to have you here.
Thank you. Thank you very much.
Dr. Rose, nice to see you.
Thanks, Tom.
So it's a complicated subject. It took years of training for you to be able to do what you do. And let's divide it up into two segments. First of all, bone tumors, and then soft tissue tumors, and then benign versus malignant. And let's talk about the relatively good to start with, and that would be benign bone tumors. How often do you see those?
Yeah, they're pretty common that we see. There are a lot of different things which can arise in the bone, most often during development in childhood, different cysts or areas where the calcium doesn't precipitate fully into the bone. And these can lead to a benign bone tumor. And there are other benign bone tumors which can arise most commonly in young adulthood, which can be locally destructive. But what separates a benign bone tumor from a malignant or a cancerous bone tumor is the benign tumor is fundamentally a local problem. So our job is to control it in the knee or the shoulder or wherever it is, because it can severely compromise or even destroy the function of the knee if it's neglected. But thankfully, they don't have the potential to spread elsewhere in your body and cause a threat to your life. So we balance our treatment to maintain function while also getting control of the tumor.
Is it more often that a tumor is benign or malignant?
More often benign, thankfully.
Fortunately, and these can occur in any age group, correct?
Yes, they're more common in children or young adults, but they can occur in any age.
And how do these kids usually present?
It's usually pain is the most common way that we find a benign bone tumor. They can also present with a mass, a bump on the leg. About 1 in 10 times, they'll have a fracture through them. So a child is doing some regular childhood activity, playing soccer, on a swing set or the like, and they'll break their arm or their leg. It's usually a very mild fracture, but it breaks through bone that's been weakened by this.
And that hurts.
Yes.
So once you see these patients and you suspect that there may be something wrong with their bone, what do you do next? I assume a plain x-ray gives you a lot of information?
X-ray is the single most important test that we have for this. And oftentimes we can come to a certain diagnosis or narrow the diagnosis down to one of a couple entities just with an x-ray alone.
And if that doesn't give you enough information, what's the next test you might do, and why would you do it?
Usually the next test would be an MRI scan. And an MRI scan allows us to look with detail into the bone and into the bone marrow to understand how a tumor is behaving there. And if we really need to, we'll get a biopsy of something. A biopsy is where a small sample of the lesion is taken for a pathology team to study under the microscope to give us a fairly definitive diagnosis.
And then once you have identified the tumor, its exact location and extent, do most of these require surgery?
No, many of them, particularly the ones in childhood, children will just grow out of on their own as the bone grows. There are some cysts which will commonly resolve with age, or if a child has a fracture through the cyst, sometimes that alone will cause it to heal. But there are a large number of these which do require some form of a surgery, usually to go in, clean out the area of abnormal tissue, often put bone graft in. If there's a worry that the bone is weakened from the presence of the tumor, we may have to put in a plate or screws to help strengthen it as it heals.
And then these bone grafts serve as scaffolding for their own new bone to grow into, and ultimately they're resorbed and the bone returns to its normal state.
That's right.
In the older individual, are they a different kind of tumor that you see, benign tumor?
You know, the more common tumor that we see in an older individual for benign tumor, for example, is a giant cell tumor bone. And this is something which is classically in younger adults up until about middle-aged. And these are locally destructive. They will dissolve away the calcium from the bone. They'll lead to pain. They'll lead to compromise of the joint function. And if you don't get a hold of them and on top of them, then they can really compromise the bone. These are ones which essentially always require surgery to go in and clear out the tumor itself, treat the margin or the boundary of the tumor, and then fill things up with bone graft or bone cement to restore the strength.
Where are they most often found?
most commonly about the knee. For reasons that we're not entirely clear about, the most common location of a bone tumor is near the end of the femur or the top of the tibia.
Yeah, interesting, and nobody really knows why. Yeah. All right, let's talk about the malignant bone tumors. Let's start with children because they're not too uncommon in children, and the most common one, osteosarcoma. Tell us about that.
So osteosarcoma is a pretty rare primary cancer of bone, and it usually arises in children or young adults. There are a couple hundred total in the United States each year, probably about 500 or 600. And this is a cancer where the cancer itself arises in the bone almost always, occasionally outside of the bone. And it'll grow pretty aggressively. And surgery and chemotherapy are the key aspects of the treatment of children with osteosarcoma. Either surgery or chemotherapy alone is very rarely successful, but the two together give a cure rate that's come about tremendously in the last several decades. We're up to probably at least a 75% rate of long-term cure in these children.
Yeah, and when I started, it was 20%. Yeah, huge
Do we know
difference.
why it happens? Is it a family history, or why do children get that?
In most cases, we don't know. There are a couple of rare genetic conditions in which we know that children are predisposed to develop bone cancer, but honestly, the vast majority of children who develop bone cancer don't have one of those conditions.
Help our audience understand the difference between, you mentioned primary cancer of bone. Tell us the difference between that and secondary or metastatic.
Sure. So I think I would say that most cancers that we're all familiar with come in adults usually, and they either come from the blood elements, leukemia, lymphoma, myeloma, or they come from the organs, lung cancer, liver cancer, breast cancer, or the like. In those cases, in an advanced state, cells from the cancer can escape, land in the bone, and grow as a metastasis. And so this is a situation where that lung cancer has spread to the bone, breast cancer has spread to the bone. Those we call secondary bone tumors because the primary source of it is the organ or the cell which lays outside of the bone. A primary bone cancer, on the other hand, is where the cancer arises directly within the bone. And again, these are much less common. About 1% or less of all cancers are primary sarcomas of bone or soft tissue.
Now, you mentioned the fact that chemotherapy and surgery are part of the regimen for osteosarcoma. There's another childhood tumor called Ewing sarcoma, but you often have a team of individuals who treat these patients, and who all is involved?
So every one of these children has a pediatric oncologist, and he or she is the person who coordinates the overall care, and they supervise and administer the chemotherapy. And then for osteosarcoma, essentially all children require surgery to take the cancer out. And unlike the benign tumors we talked about earlier, where we talked about cleaning out the tumor and filling it in, the treatment of a cancer is very different. These are resected in a single piece with a cuff or a boundary of normal tissue around them. It's a much different and a much bigger operation where the focus is primarily on getting the cancer out, and then secondarily doing everything you can to maximize function. Now, with Ewing sarcoma, which is another childhood cancer, the treatment is chemotherapy. Surgery is used in almost all cases in children, but there's also potential role for radiation as well. And so a pediatric radiation oncologist is involved in the care of those children as well.
And you do the surgery before or the chemo before?
In most cases, the chemotherapy is done for about 3 months. Surgery is done to take the cancer out, and then further chemotherapy is done. And as a part of that, you get a chance to look at the cancer after it's been treated for 3 months and analyze it and assess the response that it's having.
Now, the chemotherapy that you give these kids, one of the agents that has been around forever, one of the original agents, is called methotrexate. And the kids used to get so ill, so sick, and they would vomit all day long. But the drugs to prevent that are so much better than they used to be, right?
That's absolutely right. I mean, chemotherapy is difficult on any patient and any family with a child going through it. But the side effects, which have been so difficult in the past, while still real today, have been ameliorated a lot by advances in other supportive care.
So the 5-year survival rate for kids with osteosarcoma is now 75%?
You know, it's approaching that. I think that's a goal that we'd like to see. We're probably close to that right now. Whereas, again, it used to be in the pre-chemotherapy era, it was dramatically less than that.
And what about Ewing sarcoma?
Probably fairly similar. In most studies, long-term follow-up of Ewing's and osteosarcoma, the results parallel each other.
Any other childhood tumors that you see in your practice?
Those are the primary malignant cancers that we see. There are some rare other tumors. There are some soft tissue tumors that can arise in childhood. There are what are called germ cell tumors, which are almost embryonic remnants, which can arise down by the sacrum and those bones. But osteosarcoma and Ewing sarcoma make up the bulk of what we treat for bone tumors in children.
All right, we've been talking about bone tumors with Dr. Peter Rose, who is Division Chair of Orthopedic Oncology at the Mayo Clinic in Rochester. Time for a short break. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We're talking with Dr. Peter Rose. He's an orthopedic surgeon at the Mayo Clinic and chair of the Division of Orthopedic Oncology and an expert on tumors of the musculoskeletal system. And now you know what that means, right?
Well, musculoskeletal system? Yeah. I've got an idea after hanging out with you long enough.
The soft tissues and the bones.
I just want to know what is it that made you interested in oncology?
I've always, just since the time I was a medical student, loved taking care of cancer patients. And I like taking care of patients as a part of a team. Most of what we do in oncology is not one surgeon doing something alone. It's a surgeon working with a medical oncologist, a radiation oncologist, working with pathology, working with radiology, often working with other surgeons. And I've just always loved that aspect of the care of patients with cancer.
And it took a long time for him to be able to do what he did. So you did 5 years of residency and 2 fellowships, correct?
Yes. Yep.
One in orthopedic oncology and another in spine surgery.
That's right.
All right, so let's talk about soft tissue tumors. We'll switch gears. And again, benign and malignant. And let's talk about the benign ones. More common than the malignant tumors?
Absolutely. So less than 1% of soft tissue lumps and bumps are cancerous. So the vast majority of things that we feel, if there's a bump somewhere in our body that's in the flesh, thankfully, the vast majority are benign.
And is lipoma the most common one? Fatty tumors?
That's right. Benign fatty lipomas are extremely common. They most commonly occur underneath the skin, less than 2 inches in size. They're soft, fleshy, mobile, and usually have no clinical consequence whatsoever.
And when do you decide that it might be a good idea to take it out?
Well, first thing, if we're worried about the diagnosis for something, then with modern imaging, we can usually get a very good understanding of what something is ahead of time. And for fatty tumors, our imaging is excellent to define those. And then the decision to remove a benign soft tissue tumor would be if it's causing pain or limitation of function, or if it's showing growth. Because if it's starting to grow, ultimately it's just going to get bigger. It's going to need to be taken out. And so at a convenient time before something becomes very, very large, it's usually safer and easier to remove on an elective basis.
What are the reasons that if someone does have a lump, what are the features that would tell them that they really ought to go see somebody about it?
Probably the most concerning thing is if it's growing. So, almost all benign soft tissue lumps and bumps are latent in size. They don't grow, or if they have any growth, it's extremely slow. So something which is growing is of concern. Something which is bigger than about the size of a golf ball is something that we'd worry about, and something which seems to be deep in the muscle or the deeper parts of the flesh as opposed to right under the skin. Those are the characteristics that we find worrisome.
Pain?
Yes, although it's relatively rare for a soft tissue mass in and of itself to cause pain unless it's heavily compressing on a nerve or heavily infiltrated into a nerve, and those are less common.
It just seems, though, that patients, when you can feel that or see it, that it just gives you such anxiety worrying about it. Do you have patients that say, I don't care if it's benign or malignant, I want you to take it out?
Absolutely. And I think that's just part of being human that we all face.
It's not supposed to be there.
Yeah, that's right. Get it out. And that's okay. Most of the time, you can, if they're small, you can do it under local anesthesia and not have to have a general anesthetic. So let's talk about the malignant ones. They're pretty uncommon, but you see a fair amount here at Mayo Clinic.
That's right. So again, about 2 out of every 300 soft tissue lumps and bumps is a cancerous sarcoma. And so sarcoma is a primary cancerous tumor that arises directly from the bone or the flesh. So for soft tissue tumor, it'd be a soft tissue sarcoma.
And what makes you suspect that it's malignant versus benign?
We'd look at the growth and the presenting characteristics like we just said. And for anything that we have a worry about, you end up getting an image of it. And in almost all circumstances, an MRI scan in 2019 is our best way to image these. If we see something on an MRI scan that's worrisome, it can either be removed or biopsied so you understand exactly what it is ahead of time.
And the biopsy, you can do that with a needle now, right? And get the answer almost all the time?
Right. In about 90% of cases, we can have a tumor sampled with a small needle under local anesthesia that can get essentially a tiny little plug, about 1/16 of an inch in diameter, that can then be studied under the microscope to understand what it is ahead of time.
And why is that important?
You know, even if you know you're going to take something out, sometimes you take things out differently depending upon what they are. And for cancerous tumors, there's often a role to consider pretreatment with radiation therapy and in some cases chemotherapy before you would take something out.
So up front, you give them radiation. And why? Explain the theory behind that.
Yeah. So part of what makes a cancer, particularly for soft tissue sarcoma, is the ability for it to have microscopic seeds or tentacles that extend away from the main body of the tumor. And they're frankly too small for us to see with our eyes at surgery and too small for our imaging studies to see. But we know if we don't account for those, there's a high risk of the cancer coming back.
So if you just go in and peel something out, even though it seems like it's encapsulated and it's cancerous, it's not, right?
That's right. The risk of recurrence is probably at least 40%. And recurrence ends up with loss of function and oftentimes a very poor ultimate outcome.
Because it can then metastasize or spread elsewhere, and that creates a huge problem.
That's right. So we found that the use of radiation significantly decreases the risk of recurrence. And radiation can be given either before surgery or after surgery. That decision is a bit individualized for each different patient, but in most cases in our practice, we give radiation before surgery. And there are sometimes we actually give it during surgery as well.
If it's little tentacles, though, and the seeds, why wouldn't you? Do you do chemotherapy as well?
So chemotherapy is, at this point in time, probably best described as investigational for patients with soft tissue sarcomas. It's not experimental. We know that there can be a benefit, but we're still investigating exactly which patients and which types of soft tissue sarcomas have the best benefit. And in fairness, we think about surgery and radiation as being primarily local control modalities, meaning they're used to control the cancer where it lays in the leg. Chemotherapy, being a medicine that's carried in your blood, as its best effect if we're concerned that there's a high risk that microscopic seeds may have escaped the main cancer and be elsewhere in your body. Because as the medicine goes through your blood, it goes through all of your body. So if the seeds are there, hopefully they see it.
If you have given the patient preoperative radiation, can you go in and just peel out the tumor and have it not come back?
You know, there are times that we have to do what's called a marginal or close resection of one of these tumors if it's right against a blood vessel or right against a major nerve. We've actually found that with preoperative and sometimes intraoperative or in-surgery radiation, we can still have excellent control even when we peel things off. The key thing is you still can't cut into it. You still have to have a clean margin, but it can be clean but close in many circumstances with good radiation.
I just wanted to know, back to the benign type of soft tissue tumor, are you likely to get additional ones? Even if you remove the one that just drives you crazy, are you likely to get more?
Usually not. There are a couple of situations where people have multiple lipomas or multiple lumps throughout their body. But for most benign soft tissue tumors, we go in and we peel them off. We do what's called a marginal resection. Our dissection is just on the margin between what's normal and what's abnormal, and the risk of recurrence is usually 5% or less.
All right. The soft tissue sarcomas, the malignant tumors of the soft tissues mostly occur in older individuals. What's the survival rate with the modalities that you've discussed?
They're usually middle-aged to older adults, and their survival rate varies by the grade and the stage. So stage is whether the cancer is localized or has spread, and grade is whether it is of low or high aggressiveness. So for localized cancers that are low grade, our long-term survival is often approaching 90% if we can get a good resection on something. For high-grade cancers, unfortunately that drops down to probably the 60% range at this time. There are some areas in which we're doing better, but there's some patients who just have an adverse presentation no matter what.
Well, it really doesn't matter whether we're talking about bones cancers or soft tissue cancers. The survival rates are much better than they used to be.
That's absolutely right.
We've been talking with Dr. Peter Rose, who is chair of the Division of Orthopedic Oncology at Mayo Clinic in Rochester. Dr. Rose, thanks so much for being with us.
Thank you both.